Hello, I am Yasmin Robinson, and I'll be presenting female orgasmic disorder. A. There must be a presence of either of the following symptoms and occurs on almost all or all occasions of sexual activity. Delay in the infrequency of or absence of orgasm. Reduced intensity of orgasmic sensation. B. Criterion A symptoms have persisted for a minimum duration of approximately 6 months. C. Criterion A symptoms cause clinically significant distress in the individual. And D. The sexual dysfunction is not better explained by a non-sexual mental disorder or a consequence of severe relationship distress, not due to other stressors attributable to the effects of substance/medication or other medical conditions. Continued, there are certain specifiers specify whether lifelong the disturbance has been persistent since the individual became sexually active, acquired, the disturbance began after a period of relatively normal sexual function, specify whether generalized, not limited to certain types of stimulation, situations, or partners, situational, only occurs with certain types of stimulation, situations, or partners. Specify if never experienced an orgasm in any situation, in the severity, whether mild, moderate, or severe, and whether within those mild, moderate, severe distress, it relates back to the criterion A. For the course, there is no direct link to female orgasmic disorder. However, the DSM-5 suggests that 5 factors are associated with the course and development of the disorder. One is partner, sexual problems, and health status. So that just means that their sexual partner may have some sexual problems that they have to deal with, or their health can be a contributing factor to orgasm troubles. 2, relationship, poor communication, and the two partners may have differences in sexual desire. Individual vulnerability, there's sexual emotional abuse that might have occurred, and poor body image. 4, cultural/religious, so there may be attitudes towards sexuality and prohibitions against sexual activity. And then we have medical. A woman can also experience orgasm at any time before puberty and well into adulthood. The prevalence rates of orgasm among women that are premenopausal vary extensively. Between 8% to 72% depends on multiple factors. We have age, symptoms, duration, cultural background, and the severity of the symptoms also play a role. Rates do not include the presence of distress due to small reports of distress from women being reported. Internationally, 10% of women do not experience orgasm throughout their lifetime. Then we have prognosis, which is basically the outlook that you have. And a woman's self-esteem and intimacy can be impacted when experiencing or diagnosed with female orgasmic disorder. And typically the outlook is treatment. Number 1, therapy, so that women can get back to their satisfying sex lives. Cultural considerations. So first we have cultures that look at sex as a duty for women rather than a pleasurable activity. So an example of this would be like cultures that just look at women as people that have kids, so they're not doing it for the pleasure So women that do fall underneath these cultures do not seek help for orgasmic difficulties. One, because they don't see that they're missing out on, they don't see that this is an issue, simply because to them their duty is to give birth and not have a pleasurable and satisfying experience when it comes to sex. Next, we have sexual satisfaction is different for all women. Several women report having sexual satisfaction without experiencing orgasm. The inability to orgasm varies across world regions. From the late 19th century into the 20th century, female sexual dysfunction has experienced lots of change. In the 1930s, American psychiatry became very medicalized, psychoanalytical, and professional. Freud asserted that failure to orgasm was frigidity. Helen Wright, author of marital advice literature, stated that a woman's sexual desires are not quickly aroused nor quickly satisfied like men. The frigidity in women was linked to the lack of sexual capacity, childbirth injuries, and more. The American Psychiatric Association's Diagnostic and Statistical Manual played a major part in making female sexual dysfunction a disorder. Frigidity was in the psychophysiological genitourinary category, which at the time that was the category for most of the sexual dysfunctions that we see now, until the DSM-5 came out, and this was based, when they seen these kind of disorders, it was all based on emotional factors, and that's when the third DSM was released. And the change that occurred here was it moved from psychoanalytical to a biological approach to ensure reliability. Another thing that happened was they separated psychophysiological genitourinary and sexual deviation disorders. And then in the revised version, psychosexual dysfunction transitioned to sexual dysfunctions. And then in the fourth edition, what we know now as orgasmic disorder was initially known as inhibited orgasm. And many critics argue that female orgasmic disorder is not appropriate for the DSM. And another key thing was that female orgasmic disorder is also known as anorgasmia. Assessment. So it's pretty straightforward. It's based on the judgment of the clinician. And how you get to this judgment is basically discussing your sexual history with your clinician. And the only tests that they can or that they do perform, what I found were blood test and ultrasound test. Differential diagnosis. We have non-sexual mental disorders, which are better explained by another mental disorder like depression, substance/medication-induced sexual dysfunction, which is the orgasmic difficulties coincide with the beginning of substance/medication use. Another medical condition, the disorder is attributable to another medical condition like a spinal injury. Interpersonal factors, severe relationship distress, intimate partner violence, or other stressors are associated with difficulty experiencing orgasm. Other sexual dysfunctions, female orgasmic disorder may occur in association with other sexual dysfunctions like female sexual interest/arousal disorder. The presence of another sexual dysfunction does not rule out female orgasmic disorder. And now we have the treatments, which are sexual education, cognitive behavioral therapy, specifically the mindfulness approach, sex therapy, masturbation. Another thing is that if there are other medical conditions and medications that are being taken, um, they need evaluation before they can treat female orgasmic disorder. If there is a presence of another sexual dysfunction, that also needs to be addressed within the treatment plan. And there are no medications that have been proven to help with female orgasmic disorders. Even though I did run into some medications that said it helped, um, I did not, I chose not to put that down just because there's not enough data to say that it actually has an effect for women experiencing female orgasmic disorder. Lastly is my case. Patient X has come to her doctor due to the following symptoms. She has reached orgasm before and is now having difficulty. The duration of her symptoms for 8 months. She's been married to her partner for 4 years. She noticed that it occurred after her second child, and she expresses concern for her relationship and body image. Patient X's differential diagnosis is heavily associated with non-sexual mental disorders, and I decided to go with this just because of the concerns that she expressed. She's worried about her relationship, um, in the poor body image, and these can lead to depression or anxiety disorders, which could be impacting her sexual function of coming to orgasm. And that is all.